Hello and welcome to our session titled, What's Weight Got to Do with It? Obesity, COVID-19, and Black America's Health. I'm Ted Kyle, a pharmacist from Pittsburgh and a member of the Obesity Action Coalition's Board of Directors, as well as an advocacy and policy advisor to the Obesity Society. Today, we're going to discuss obesity in the United States and how this disease factors into major public health challenges such as mental health, healthy aging, and maternal health. Our experts will also discuss the importance of increasing access to obesity care and community-based programs, and the need for public education and the association between obesity and other chronic diseases, and how health conditions increase the risks when individuals are exposed to infectious diseases like COVID-19 and the Delta variant. But first, I want to thank today's event sponsor, Novo Nordisk, a global healthcare company committed to identifying new and better treatments for people living with obesity. Also, to open our first discussion, I'd like to thank our panelists for joining us, and we'll introduce you to each one of them. Starting first with Dr. Michael Knight. He is a primary care and obesity medicine physician with the George Washington University Medical Faculty Associates in Washington, D.C. He is also serving as assistant professor of medicine and chief quality and population health officer at the George Washington University. Next, I'm pleased to introduce C. Virginia Fields, the founder and CEO of the National Black Leadership Commission on Health, an organization based in New York and founded in 1987. One of the oldest organizations of its time, the National Black Leadership Commission on Health promotes health equity through advocacy, policy, and action. Ms. Fields is also the former borough president of Manhattan. Next, we have Katie Adamson, the Vice President of Programs and Policy with YMCA of the USA, the National Resource Office for the nation's 2,700 YMCAs, and she is located in DC. Ms. Adamson has over 30 years of experience in health policy and helped draft legislation establishing the National Diabetes Prevention Program. Finally, we have Tammy Boyd, Chief Policy Officer and Counsel with the Black Women's Health Imperative. It is the first nonprofit organization created by Black women to help protect and advance the health and wellness of Black women and girls. Tammy Boyd was instrumental in helping elevate the National Center on Minority Health and Health Disparities into an NIH center. So I'd like to start with Dr. Knight. Dr. Knight, according to the Centers for Disease Control and Prevention, 43% of adults in the United States have a body mass index over 30, which is a clinical marker for obesity. And among African Americans, that prevalence is 50%. Members of racial and ethnic minority groups are more likely to have obesity, along with persons living in rural areas, persons who do not have a college degree, who are lower income earners. So can you tell me a little bit more about what obesity is and why there are these disparities based on a person's race, ethnicity, geographic location, and socioeconomic status?
Thank you, Ted, and I'm so excited to be a part of this panel to talk about this very important topic. As you outlined, obesity is not just a physical trait. It is a chronic disease that is complex, that is relaxing and remitting, and that affects individuals for large portions of their life. The reality is that the number of individuals suffering from obesity in the United States and around the world continues to grow at epidemic proportions. In addition, in the United States, communities of color, as you've outlined, bear the burden of disease. When we think about why that is, we know that it's not because there is some kind of minority gene that involves or includes obesity. The reality is that when we think about the social determinants of health, when we think about our communities, when we think about the factors that lead to increased risk for obesity, those are disproportionately present in communities of color. When we think about access to healthy foods that are high in nutritional quality and that are low in caloric content, those are incredibly expensive, as well as not always present in every community. It is a shame that in 2021, in the United States, it continues to be a privilege to follow a healthy lifestyle. And I think that's the reality. When we have food products, when we have access to food that are priced much more considerably and much more accessible to communities, we then should not be questioning, well, why do these communities not have access to the kind of foods that would promote healthier lifestyles? We also have to think about the access to areas where people can be physically active. You know, I know we'll talk about organizations such as the YMCA that have been a center for activity for many communities, but unfortunately, we still have communities that don't have access to safe areas for children and adults to be active. Gym memberships, a variety of things that for many of us seem like an everyday expense can be out of reach for many individuals. And so when we continue to see an increase in communities of color, in communities that have been underserved, we should also not be surprised when we also see an increase of comorbid conditions such as diabetes, high blood pressure, heart disease, stroke, kidney disease. The list continues. And so I hope in this conversation, we're not only going to talk about statistics, but we're also going to talk about solutions, because we've been talking about statistics for quite some time. And I'm looking forward to continuing that conversation.
You mentioned that obesity is a condition that puts individuals at higher risk for other chronic diseases. Right now, we're experiencing a historic public health crisis with COVID-19 and the Delta variant. What are some of the learnings that we have from this experience? And can you talk a little bit about why individuals with obesity are more at risk for bad outcomes with COVID-19?
Thank you, Ted. This is so important because when we started looking at the data for why certain individuals were having worse health outcomes infection during this pandemic, we noticed very quickly that individuals who are suffering from obesity had an increased risk of poor outcomes from COVID-19 infection. And it's not just that individuals with obesity are more likely to have additional chronic diseases, though that does play a role. So the first thing is thinking about many individuals who suffer from obesity also suffer from diabetes, from high blood pressure, from heart disease, from other conditions that also increase the risk of poorer outcomes. When we know that when the body is dealing with chronic disease, we see level of inflammation, levels of immunity decrease, and that increases the risk for infection and poor outcome. But in addition to that, even taking away the comorbid conditions just by having increased weight as an independent risk factor was significant for negative COVID-19 outcomes. There's a couple of reasons. Number one, when individuals have increased obesity or increased weight, that can cause restriction on lung capacity. We know that COVID-19 often attacks the lungs, and so we have to use all of the reserve capacity in our lungs possible to ensure continued oxygen flow to our tissues and our brain that need it so much. When we have individuals suffering from obesity, many times the increase in weight that's carried in the chest area, in the abdominal area do not allow for full expansion of the lungs. Number two, we know that individuals with obesity, that is an effect on the immune system. We see decreased activity and decreased functionality in the cells of our immune system that are supposed to fight disease. Number three, one of the pieces with COVID-19 we know was increased risk for blood clots. A lot of the outcomes that we were seeing with regard to stroke, with regard to other issues, were also related to increased clotting. And we also know that individuals who suffer from obesity can have an increased risk of blood clots. And finally, the chronic inflammation that I've talked about. So those are some of the things we're still learning. We're still trying to understand, but from what we know right now, obesity is an independent risk factor for worse COVID-19 outcomes. And that's why it's so critical that we continue to have this conversation and address how we can overcome this epidemic of obesity in the United States.
Dr. Knight, we're really lucky to have you here as an expert in obesity medicine. And as you talked about it, you described it as a disease, which is not something we always hear out in the community. I wonder if you would share a little more about what treatment of this disease involves and any barriers that may exist for patients seeking obesity care.
Thank you, Ted. That's such a great question. You know, when I became board certified in obesity medicine in Washington, D.C., I was one of about 7 physicians in the district that had that certification. When we look at the numbers of individuals suffering from obesity in Washington, D.C., we should have hundreds of physicians who are specializing in this. And it's critical for us to understand that it is a chronic disease that requires complex treatment. That does not include just saying, eat less and exercise more, right? We know that's a critical part to what's happening, but we as a healthcare organization, a healthcare field, as well as a community in general, have to acknowledge it's not just pushing away from the table. Individuals who are suffering from obesity, there's a physiologic and a pathophysiologic pattern of hormonal signaling and a variety of issues that not only cause obesity, but also make it extremely difficult for those individuals to lose weight, even with caloric restriction, even with a work to increase physical activity. When we think about treatment, we're talking about nutrition. So not just how much you're eating, but the types of food that you're eating, the carbohydrates, proteins, fats, thinking at the macronutrient level and understanding how your body reacts to that. For example, if you're suffering from insulin resistance, pre-diabetes, diabetes, how you process carbohydrates is going to be very different from someone who doesn't. Number 2, physical activity. So not just moving around and getting my steps in, but also thinking about moderate and high intensity physical activity, cardio work, and how long it's going to be done every day during the week. Number 3, medications. There are individuals who are eligible for medications to help them lose weight. It's not a crutch. When someone has high blood pressure, we don't see high blood pressure pills as a crutch. It is a necessary intervention to help someone overcome a chronic disease. Same with obesity. The barriers, and finally, also surgery. For certain individuals who are eligible, bariatric surgery is an excellent choice to help combat obesity. When we talk about barriers, we're talking about insurance coverage. We know that today we don't have equity or parity in coverage of anti-obesity medications in the commercial market with Medicare and with other government insurance plans. We also know that there are challenges with getting coverage for surgical intervention. So we have work to do. We have work to do to understand that obesity requires complex care, and we need insurance to also cover that care so that it can be accessible to every individual that needs it, particularly in communities of color that unfortunately are most likely to go up against these barriers that continue to be there for effective treatment.
Thank you so much for that. That was amazing to pack so much information into such a short time. We could sit here and talk for, I think, the whole hour. But I want to say that I am really grateful to have Miss Virginia Fields here to really teach us a few things Obesity and COVID, Ms. Fields, are a topic that you are familiar with as part of your work leading the National Black Leadership Commission on Health. I wonder if you could tell us a little more about your work and what policymakers should know as they respond to the Delta variant and in addressing future disease pandemics. Ms. Fields, you're still on mute.
And that happens, unfortunately. Anyway, I was saying, as I listened to Dr. Knight, that we need you across this country. You're absolutely correct. We need more of you. Thank you so much. That was very informative. The National Black Leadership Commission on Health, which formerly was the National Black Leadership Commission on AIDS, which was founded in 1987. But in 2019, the organization changed and became the National Black Leadership Commission on Health, with expanded health focus areas, still including HIV/AIDS, hepatitis C, breast cancer, prostate cancer, cardiovascular disease, mental health, and diabetes. Recognizing that these are perhaps the leading health diseases disproportionately impacting Black African Americans. And we adopted the new name, the National Black Leadership Commission on Health, and a new mission, which is to champion the promotion of health and prevention of diseases to reduce disparities and achieve equity within the Black communities. And working through our 12 national affiliates, we achieve our mission through advocacy, policy, and actions, and working with a broad spectrum of leaders, including elected leaders, clergy, consumers, providers of services, media, and other stakeholders, in order to do the community mobilization, to do the outreach, all of what is necessary to achieve the work of our mission. So, of course, when the COVID-19 struck through our 12 affiliates and building on our strong community mobilization and outreach efforts, we quickly responded to address the significant needs of our target population that have been hardest hit by the virus, including those with disproportionately high infection, morbidity, and mortality rates. And of course, the social and structural determinants of health are an integral part of the health systems and the work that we do and have been integrated into all of our programs. We recognize that these same communities now have significantly lower vaccination rates. So what we recommend for policymakers to do and to continue to do covers some of what Dr. Knight mentioned, and I'm sure what we will be discussing as we go throughout the panel discussion. One, we need to continue making resources available for COVID testing. We cannot step away from that and assume that because we're in the vaccination mode, that the emphasis must just be there. So we need to continue making resources available for COVID-19 testing. We need to work with community leaders to establish and support vaccine hubs in targeted zip codes that are designated in each one of our cities by our health departments. We need to equip community stakeholders to be able to provide resources and give them the assistance so that they can work with various groups in their community and their constituents. We need to expand and engage a variety of community stakeholders who typically are not included We work with clergy and we know the importance of their work in a community. But at the same time, we need to bring in those tenant association leaders, those block leaders, those people in the community who know and have relationships and can influence whether or not a person gets tested or not. We need to better equip healthcare professionals who have offices in local communities as doctors, nurses, dentists. And we need to continue to invest in training so that we can empower leaders to build sustainable structures. So I think as policy leaders, those are the kind of investments that we must continue to make. And I think that would help us even as we deal with the Delta variant. And of course, social media platforms are very important to engage the community. So hopefully, as the panel discussions go forward, we can address some of these more specifically, but those are certainly some things I think that policymakers must take into consideration, and that represents the work that our agency and organization continues to do, and we see impact.
Excellent, thank you so much. I want to quickly shift to the subject, Ms. Fields, of mental health and obesity. Data show that Black women are the most at-risk group for obesity. There are also studies indicating disordered eating, such as binge eating, are more common for Black women and girls than women of other races and ethnicities. Understanding your background as a social worker, how do social factors like trauma, poverty, and racism affect Black women's health and weight?
Well, certainly obesity is caused by a number of factors, as Dr. Knight pointed out, and trauma, poverty, racism are just a few of those factors that impact weight. If a person, a Black woman, is experiencing any level of trauma or living in a community that lacks a lot of the resources like walkable neighborhoods, safety in a neighborhood, access to nutritious food, access to quality food, even at the grocery stores, all of this affects one's weight and their behavior. A tendency to go on binges as far as eating and as far as just not exercising due to lack of exercise classes and equipment in a community, which I know we're also going to talk about. All of that affects the mind and the mental state and the conditions of women, and with Black women and girls who live in many of these communities that do not have walkable, that are not walkable neighborhoods, do not have the equipment for exercising, nor the money to go to health clubs. This is what we are seeing. All of that also factors into what we know as structural racism, social determinants and structural racism. So let's invest in our communities. Let's make them more livable. And I think we can begin to see a turnaround in some of these areas as it relates to obesity.
Well, in the minute we have left, Ms. Fields, I want to ask you, as a former elected official and longtime health advocate, what should we be doing to create a stronger sense of urgency about adult obesity?
Well, advocacy, we know, is simply the process of educating. And I think one of the things we should do, we need to talk more about adult obesity. We need to make the case. We need to take it to our elected officials. We need to help educate them about the impact of obesity and as it relates to other comorbidities, whether it's diabetes, heart disease, certain forms of cancer. But it is the education that is needed, and we need to raise our voices. Like some of the other, health disparities as we talk about, we don't see it with obesity. So let's start by boldly telling the story about adult obesity, its impact in terms of our lives, and work with our legislators to educate them to pass appropriate legislation. And if legislation is not on the table, to introduce legislation.
Thank you so much for that. I would like to keep going with you. This is such a privilege, but I need to move on right now to Ms. Katie Adamson with the YMCA and ask you, Katie, obesity is a lifespan health issue, so certainly it's important to discuss solutions. Currently, there are many important federally supported programs to prevent or reduce obesity, such as the CDC's Chronic Disease Prevention and Health Promotion Program, USDA's programs on nutrition, Department of Transportation programs, and especially those, I want to ask, what about those that are especially designed to reach African-American communities? What is being done to make them more accessible to a greater number of people?
So thanks, Ted, and thanks for having the Y here today. Just a few things on the Y that we believe all people, regardless of age, income, or background, should be able to live life to their fullest, healthiest potential. We reach into 10,000 communities and serve about 21 million Americans, including about 8 million children and youth. And I want to say that the pandemic has hit the Y movement really hard. Our 2,700 Ys lost about 3 billion collectively. But as our buildings shut down, we moved out into communities to provide social service needs like childcare for frontline and emergency responders, hungry families, food, and we reached in to socially isolated individuals. So it's been a year. It's been a tough year for us. So I'll pivot back, and I think I've got two questions here from you. So I'm going to try to answer both of them in order. So I'll agree with you, yes, that obesity is both a lifespan issue and that family choices also impact weight. But since 80% of health outcomes are influenced where we live and work and go to school, ultimately the choices we make are often greatly influenced by the choices we have, as we've heard from previous speakers. And so at the community level, the Ys worked for the last 2 decades to change the physical environments in communities so that access to safe, affordable places to walk, bike, and play are available. And access to fresh, affordable food is also readily available. And sadly, there are less resources from the federal government to do this type of work today than there were a decade ago. But after working in 20 states and over 245 communities on this work, much of the environmental policy and systems change has sort of been built into our culture of how we work at the Y. So more farmers markets, community gardens, grocery stores in low resource communities, policies supporting recess, PE in school, and safe routes to school, and I could really go on. And as an organization, the Y partnered with our other friends in the out of school time arena, and we introduced healthy eating and physical activity standards within our childcare and youth settings, so that any time spent in the building would provide our children and youth with access to the healthiest opportunities and environments. So fresh and healthy snacks and as much physical activity, including outdoor activity, as possible. And CDC will soon be supporting both the Y and the Boys and Girls Club to develop a curriculum and build a national roundtable on how we train out of school time staff on trauma-informed approaches to working with our kids. On a family and individual level, the Y researched many lifestyle health programs and found the most widely disseminated and extensive child weight management program in the world, MEND. It stands for Mind, Exercise, Nutrition, and Do It. We renamed the program Healthy Weight in Your Child. Studies have shown that this program models effective in reducing body mass index, waist circumference, reducing sedentary behavior, increasing physical activity, and improving self-esteem. It's a 25-session evidence-based program for children and their families living with obesity. The program includes a family information session, and it's carried out 25 sessions over 4 months. So while family-based weight management programs are essential in addressing childhood overweight and obesity, and it needs to be covered by insurance. We must also continue to advance these organizational and community-wide approaches to making healthier choices available to all. These approaches are more important now than ever, as we see most American adults having put on 25 plus pounds, and children also substantially seeing increased weights and sedentary lifestyles during the pandemic. And they're also struggling deeply with mental health issues. And secondly, Ted, I think you asked me about those different programs. So the second question about CDC's chronic programs and the USDA programs, and also how we're addressing different programs that specifically targeting racial and ethnic populations. So I'll answer the second question there, which is we've worked with CDC over the past 2 decades to advance strategies to improve health by preventing and controlling chronic diseases, including obesity. And we've advocated with other patient advocacy groups and public health groups for a tripling of the Chronic Disease Center at CDC. If successful, the amount we would invest in the prevention programs at CDC would still only represent 1/10 of what we spend on healthcare in this country. And 90% of healthcare spending is for the treatment of people living with one or more chronic conditions. So I feel like 1/10 of 1% is not too much to ask for. The pandemic's created so much hunger in this nation, and so the USDA food and nutrition programs have become a lifeline for children and families in our communities. The Y distributed 57 million meals this past year, and many were to first-time hungry families. We would not have been able to do this without the summer, supper, and after-school meal programs at the USDA, and the Y took over many of the school lunch programs. The Y partners with Safe Routes Partnership and the CDC to release a biannual report that ranks our states on the policies to support walking and biking. And then we work on the ground in communities and at the state level to document barriers to walking, biking, and rolling. And then we try to advance policy strategies so that all communities can have access to safe routes through their communities. And there are big wins in the infrastructure bill for this work if it passes. We have fought for years for one of the only federal programs addressing racial and ethnic disparities in this country, or the REACH program, the Racial and Ethnic Approaches to Community Health. It focuses specifically on communities of colors and aims to reach, to advance policies and programs that drive access to healthy food and physical activity in Black and Brown communities. Many times REACH was eliminated or slated for elimination with funding, but we finally are seeing the funding grow, which will give more communities the opportunities to access this funding. And a few weeks ago, a bipartisan congressional social determinants of health caucus was launched, and they have requested input on the major barriers and opportunities for addressing the social drivers of health. Their request for information is due back by September 21st, and we encourage all to weigh in. But I want to make sure I briefly discuss the National Diabetes Prevention Program, which the Y helped translate into community and established a federal program at the CDC to ensure that all community-based organizations, when recognized, could deliver the program. The National Diabetes Prevention Program was modeled after the NIH studied diabetes prevention program, showing that we could reduce the incidence of diabetes by 58% if individuals could lose just 5 to 7% of their body weight, or about 11 to 13 pounds on average. Black and Brown communities suffer much higher rates of diabetes than white communities, and we have learned that other social drivers of health impact outcomes, such as lack of transportation, access to food and physical activity, and childcare, and can lead to less weight loss in under-resourced communities. So we have been working with CDC to modify the program to allow for a 4% weight loss goal and to help further provide support to sites as they work to address social determinants of health. So I gave you 2 answers there for 2 questions. I hope that's okay, Ted.
That was just great, and what a lot to think about. In the couple of minutes that we have left, I just want to ask you about healthy aging. Americans are living longer, and because of that, public health experts are saying that healthy aging needs to be a priority. So what exactly is healthy aging, and what are some programs in place to improve obesity-related outcomes, and what are some areas where we could improve?
Great, and thanks for that question. I know there are a lot of studies out there that show if you're staying physically active and eating well, you can live as long as 7 to 10 years more and stay out of some of the longer term care facilities. So just those basic lifestyle health issues are fundamental. And I mentioned the National Diabetes Prevention Program, which really is a lifestyle health program. And I want to share with you a moment, in a moment, the success and challenges we've had with bringing that program to Medicare for America's seniors. But I want to first add that, as we heard earlier, overweight and obesity are major contributors or complicating factors to a host of other diseases. And so the Y has worked to create a suite of programs that can address not just diabetes, but also address arthritis, high blood pressure, falls, and cancer. As with the National Diabetes Prevention Program, the Y looked to the best research programs and found partners to help us measure returns on investment for these community-based programs. When you are a community-based organization like the Y, who often relies on community lay workers for their programs, you have to prove that you are evidence-based and worth an investment for anyone to take you seriously. It's just that much harder. And so we've had to prove in a big way when we were awarded a grant from the Center for Medicare and Medicaid Innovation in 2012 to prove that the National Diabetes Prevention Program could be delivered to Medicare recipients and achieve those triple aims of better quality, better care, and reduce healthcare costs. The Y was able to reach 8,000 Medicare recipients with the NDPP and showed we could achieve that 5 to 7% weight loss. We could reduce spending on medications, ER visits, and save Medicare $2,650 per individual over 15 months. So the Medicare actuary certified the results and announced the first ever community-based program to be part of Medicare and in an expansion model. So we're still testing it. Unfortunately, the system was set up in such a way, and maybe not surprisingly, but it's very hard for community-based organizations to become suppliers from a bureaucratic and administrative standpoint. And the payment model makes it financially challenging to launch and sustain the program at a community level. We don't have startup funding, and the costs associated with recruitment and referral and data and payment collection systems can be extensive. These are things the healthcare system already has, but community-based organizations don't. And so additionally, there were no accommodation for those reaching those that would face these social drivers of poor health and who would not likely reach that 5% weight loss, but rather only reach a 4% goal. So in fact, serving under-resourced populations would put a supplier at risk of losing their recognition status because they were really trying to help those who needed it most. And so we've been advocating for a change that would enable 4% weight loss in the program. So there's no disincentive for serving those with less resources, but rather incentivizing it. Also, if individuals do not hit that 5% weight loss goal, the supplier is given no additional resources to help those individuals complete the program and potentially hit a higher weight loss or maintain the weight loss they achieved. This is a health equity issue, and CMS needs to address it head on. And because this is a CMS issue, if we don't fix these challenges with MDPP, it's unlikely we're going to be able to fix these challenges for intensive behavior therapy in terms of how community-based program suppliers fare in the system. And that is important as we continue to press for the Treat and Reduce Obesity Act, which would provide coverage for intensive behavior therapy, which with a much broader net of providers, including community-based organizations. So
thanks so much, Katie. And obviously, we could go on talking about this for quite a while, but I want to get on to Ms. Boyd because there's so much going on at the health imperative. I wonder if you could tell us a little bit more about how active the Black Women's Health Imperative has been on federal policies to expand comprehensive obesity care access. What policy should policymakers and the public support to help reduce the effects of obesity?
Yes, and absolutely, that's a great question. So at Black Women's Health Imperative, as mentioned, we are focused on addressing physically, financially, emotionally, really the issues around facing Black women. And so a part of that, we launched a program called Reclaim Your Wellness with from Black Women's Health Imperative and in collaboration with Healthy Women. And we launched it to really raise awareness of obesity as a national health crisis in a manner that is free of stigma, judgment, and bias. And it's a multifaceted campaign. It's focused on educating women about healthy eating and staying active, ensuring women have access to science-based comprehensive care, and also bringing leaders together from across the industry to make policy changes to help reinforce active and healthy living. And finally, we're striving to reverse our nation's costliest and most prevalent diseases. But a part of this, we are raising awareness and educating Congress and the administration about, updating Medicare's coverage policies to support treatment and prevention of obesity. We've had several meetings, talking to policymakers about how they can address obesity. And a part of that, Black Women's Health Imperative, and similar to what Katie mentioned, we also participate in the DPP program, the Diabetes Prevention Program. And so we look at a continuum of care. So not just diabetes, but then also on the other side of the spectrum, as Dr. Knight also mentioned, there's the bariatric surgery aspect, but then there's also the anti-obesity medication aspect. And so right now there is a lack of coverage for the anti-obesity medications. And so we believe that this is key, particularly for Black women that are disproportionately overweight or obese. And so continuing to educate policymakers about that and to coverage of anti-obesity treatments.
Thank you so much for that. It is remarkable, some of the work that you've been engaged in. And I'd like to shift a little bit. America is also facing a maternal health crisis. Numerous studies tell us that that with obesity, a woman faces a greater risk of pregnancy complications, including preeclampsia, gestational diabetes, stillbirth, and cesarean delivery. Pregnancies in and of themselves are very complex. Is there more that policymakers can do to address and raise awareness of the role of metabolic health going into pregnancy and in the process of planning pregnancies?
Yes, it's an excellent question. I mean, you just mentioned two critical issues for Black Women's Health Imperative, the Black maternal health crisis, and then also obesity. As mentioned, African-American women have the highest rates of obesity, are being obese, or being overweight compared to other groups in the United States. About 4 out of 5 African-American women are, 4 out of 5 African-American women are overweight or obese. And then in terms of maternal health, the Black maternal health crisis, Black women are 3 to 4 more times likely to die in childbirth. And if we're talking here in Washington, D.C., that number is even higher. And so there's been a lot of activity around the maternal health, Black maternal health issue. Congressional Black Caucus members, Congresswoman Adams and Congresswoman Underwood created about 2 years ago the Black Maternal Health Caucus. And most recently, they introduced the maternal omnibus legislation, which also on the Senate side, Senator Cory Booker was the leader in that. And it's really the compilation of 12 bills. It stems from looking at making critical investments in social determinants of health, providing funding to community-based organizations that are working to improve maternal outcomes and promote equity, growing the workforce, the perinatal workforce, to ensure that every mom in America receives culturally sensitive maternity care and support. And the list goes on. It also includes around pregnant women and vaccinations. But in that, directly addressing obesity is not included. And so we know that, for example, also as we continue to explore the Black maternal health crisis, and VP Harris, and when she was Senator Harris, she introduced the legislation in the Senate. But this has also been one of her key platforms, even as VP. Congressman I won't say Congressman, but Secretary Becerra also held a roundtable around the Black maternal health crisis. And so as we begin to raise awareness about the Black maternal health crisis, and I think it's important, and we are advocating Black women's health imperative, to really look at the intersection of obesity and its impact on maternal health, on Black maternal health. And so for policymakers, again, just simultaneously addressing obesity in the context of Black maternal health is key, in addition to advocating and educating Congress about TROA.
Thank you so much. I just want to really express my appreciation for the strong advocacy that the Black Women's Health Imperative has brought for public education and awareness about obesity and its impact on Black women and their health. I wonder if you could tell us a little bit more about how the imperative got involved in this work, and what are some of the things that you hope to accomplish this year with regard to this?
Yes, absolutely. So going back, how we got involved in this work really stemmed from initially addressing through the Centers for Disease Control and Prevention. When they launched the NDDP, the National Diabetes Prevention Program in 2012, and they funded the Black Women's Health Imperative for 5 years. It's one of its original 6 national organizations to take evidence-based interventions to scale. And then BWHI was awarded legacy funding in 2017 to expand our provider network. So since 2013, BWHI has partnered with 18 organizations in 13 states, offering our branded called Change Your Lifestyle, Change Your Life Change program. While BWHI places special emphasis on Black women, we also, are supportive of anyone meeting the CDC eligibility guidelines to participate in the program. We've also expanded our vision for COIO Squared to include the prevention and self-management of chronic disease, focusing on those conditions that are obesity related, or can potentially be prevented or managed through positive lifestyle change. So that, again, we have expanded that vision even more, and again, looking at the full continuum of healthcare. So diet, exercise, all the way on the other side of the spectrum, anti-obesity medications, and bariatric surgery. What we are doing now to continue, we are now going to phase 2 of our Reclaim Your Wellness initiative. And a part of that is we are holding a series of virtual conversations. We're really going deeper into the community. We're now beginning to partner with other organizations in the Black and Hispanic community, also the rural community. And we are participating in blogs. We're putting out more information and really trying to, again, raise the awareness around obesity and the need to address it in the communities of color.
That's fantastic. I just really want to try and draw this all together. There's been so much here, starting with Dr. Knight, Ms. Fields, Ms. Adamson, Ms. Boyd. So much territory we've covered. We could probably talk for a couple of more hours, but this has really been a compelling discussion about obesity, and drawn some important connections between that and COVID-19, and really the important role that this plays in Black America's health. Some of my major takeaways were really that obesity is a serious health equity issue and one of the most dangerous risk factors for severe cases of COVID-19. And I wonder, just if I could ask you, Tammy, if you could summarize for us some of the important elements of the Treat and Reduce Obesity Act that would help with addressing this factor.
And yes, so the treatment, so the TROA, the Treat and Reduce Obesity Act, is HR 1530. On the Senate side is 595. And again, it seeks to cover for Medicare coverage of anti-obesity drugs. But I can probably defer to someone else in terms of the other aspect of it's two parts to TROA. But I can defer to maybe Dr. Knight if he wants to sort of expand on the first aspect of TROA.
Dr. Knight, is there anything that you'd like to add?
Sure. So one of the things is really looking for parity in coverage for treatment. When we think about Medicare as well as some other government programs, there is often an exclusion for coverage for anti-obesity medications. And that's a huge challenge. And so that's really the focus of the legislation, removing those barriers. I mean, when you think about it, you know, it's almost like you have cancer and you have an insurance plan that says we're going to pay for everything except cancer medication. So that's what we're talking about, removing those barriers so that patients can have a conversation with their healthcare provider and make a decision together about appropriate treatment options for them. And if that includes anti-obesity medications, it should not be the insurance company that is standing in the way of that. And unfortunately, that's the case with Medicare. And as we know in the health insurance marketplace, many other insurance companies will follow the work that Medicare does. So though we do see some coverage in some other insurance plans, I would say across the board, we don't have parity for coverage for anti-obesity medications.
The other thing that I'll mention, and we're running low on time here, but I do want to talk about the behavioral part of this, where for some time now, CMS and Medicare have covered intensive behavioral care. There is the diabetes prevention program and intensive behavioral programs to treat obesity that have been there, but the restrictions on those programs have been so tight that really even just a fraction of 1% of the people who could medically benefit from those programs have actually gotten access to those programs. So one of the things that the Treat and Reduce Obesity Act is designed to do is expand the number of providers who could actually provide that care, who are medically qualified, and actually get that care to more people. I just want to say to save and improve the lives of people living with obesity, we really do need to address better the social determinants of health, really support the Treat and Reduce Obesity Act to increase access to care and effective programs such as the Diabetes Prevention Program and the Medicare Intensive Behavioral Therapy Program. This has been a fantastic discussion, and one that I'm grateful for because of the great expertise we've had here on this panel today. I want to say thank you very much, and I look forward to working more with you on these programs in the future. Thank you.